Hi. So this case is basically of a woman who hails from Zimbabwe, has been having quite a decent amount of complaints, like there's shortness of breath, there's loss of appetite, there's night sweats, and she's lost almost 5 kgs of weight in the last few months. There's a dry, unproductive cough, and on auscultation, we are having the presence of inspiratory crackles. All of this, when we combine it with the lab parameters, we are going to see a diffusely or a grossly reduced lymphocyte count. Considering the belt that she's coming from, that's the West African belt, with such a low lymphocyte count and such constitutional symptoms as we have described already in this case, points very much to a case of HIV. Now, if you look at the chest X-ray, you'll be finding bilaterally there are presence of diffuse interstitial infiltrates. Often there can be bibasal cysts, very small size cysts located in both the lower lobes of the lung. Each of these cysts also carries a risk of rupture leading to pneumothorax. So pneumothorax is very common in these patients due to the rupture of these cysts. Only 10% of these patients, however, can land in pneumothorax, and that pneumothorax will be presenting as an acute respiratory emergency as we know it. On the basis of whatever we have, the information that we have based on the lab parameters, the clinical features, and along with, we are also having the chest X-ray, which is showing diffuse interstitial infiltrates. The most likely diagnosis in this patient of HIV happens to be a specific pneumonia, which is called the pneumocystis jirovecii pneumonia. Pneumocystis jirovecii is a very common opportunistic infection. It's an opportunistic fungal infection that is found in patients of HIV, especially when the CD4 count drops to below 200. How do we diagnose? We will either be doing a Ball staining of the sputum in case of when we have the patient who is expectorating. If the patient who is not expectorating, we can give certain agents by which the patient will be able to induce sputum, and on this sputum we can be going for BAL, or you can be going for immunofluorescence tests as well. When you do BAL and you stain the fluid with a certain specific stain called GMS, or the Gomori methamin silver stain, you find crushed ping pong ball appearance, jet black colonies with crushed ping pong ball appearance. That is the histopath of this fungal pneumonia, and this is the most common the most common opportunistic infection that we will get in HIV patients. However, there is one option in this question, which is CMV. CMV happens to be the closest differential to this case, but then even though CMV can be found in patients of HIV and immunocompromised states, it is also found in a case where CD4 count is less than 200. But the only factor which will differentiate CMV from pneumocystis, especially for this question, is the absence of the gastrointestinal and visual symptoms. We know CMV has the predisposition to affect the retina, leading to CMV retinitis. In the absence of GI symptoms like diarrhea, in the absence of abdominal emergencies or abdominal pain or severe mesenteric ischemic kind of pain, which is most commonly the presentation of the gastrointestinal manifestations of CMV, that is, the CMV GI symptoms, the CMV retinitis, or the ocular symptoms. The absence of all of these symptoms of cytomegalovirus, that is commonly the name of CMV, the absence of all of these symptoms warrants more towards us diagnosing in the favor of pneumocystis jirovecii. The other options like Legionella is directly ruled out. Legionella is a bacterial infection, and it will come with a lot of other symptoms like diarrhea, hyponatremia, deranged liver function tests, which is definitely not something that we find in this question. There's another option, which is pulmonary embolism. Although there is a sharp pleuritic kind of chest pain in pulmonary embolism, however, we do not have any significant contributing factor to the development of thromboembolic episodes in this patient that rules out pulmonary embolism. Another option, which is nocardiosis. Yes, nocardiosis can also occur in immunocompromised states. However, nocardiosis will come more with the history of abscesses, be it skin abscess, be it brain abscess. So the absence of a history of abscess in this question again rules out nocardiosis. So that's the case for us, pneumocystis jirovecii. I told you about the clinical presentation. I told you about the diagnosis. The treatment is usually with cotrimoxazole, and as I said, 10% of the patients having lung cysts bilaterally in the basal lobes of the lung have a risk of rupture and developing pneumothorax. That's the case for us. That is pneumocystis jirovecii, or PCP pneumonia, as we commonly call it. Thank you so much.